This conference will now be recorded.
Okay, then as last class we have discussed this Meniere's disease. We need to discuss about the treatment part. But before going to the treatment, we'll just once recap briefly what is Meniere's. I'll just go through the slides one, and then we will proceed with the treatment part. So Meniere's, as it was first described by Prosper Meniere, and the symptoms were vertigo, progressive sensory neural hearing loss, tinnitus, and oral fullness. So these were the first symptoms which were observed, and if you have these symptoms, then you can classify it as Meniere's. So the definition was a disease of membranous inner ear characterized by deafness. And the deafness should be generally a sensory neural hearing loss. Then vertigo should be this. Vertigo will be the first complaint actually. Then tinnitus followed by and the oral fullness. If these complaints are there, and histologically, if you can confirm if, as the distension of the endolymphatic system, then that is your Meniere's disease. Okay. So according to the criteria, AAO criteria, we have discussed as possible, probable, and confirm. So the possible is if you have a spontaneous episodic vertigo without any documented hearing loss, and SNHL fluctuating or fixed with disequilibrium, means any vertigo, but with no definitive episodes. As an episode means it should be there like for around some seconds or minutes or some hours, like that. If there is no such no definitive episodes or no documented hearing loss, only with vertigo, then you can call it as possible Meniere's disease. Well, you have to exclude all the other causes. And what is a probable one? At least one definitive episode of vertigo, and audiometrically you need to document at least once, and tinnitus or oral fullness may be present with other causes excluded, will be a probable. Whereas definitive is 2 or more definitive spontaneous episodes of vertigo 20 minutes or longer. So if the patient has a vertigo episode of around 20 minutes or longer, and that too he has 2 or more episodes in history with a documented audiometrically documented hearing loss at least on one occasion, then and along with tinnitus and oral fullness, then it's a definitive one. So probable, possible, probable, and definitive. So this was the criteria. Then comes the physiology. You know that perilymph and endolymph and membranous labyrinth. Okay, so the perilymph is present in scala vestibuli and endolymph is present in scala media. Okay, so these were the diagrams. So this is the perilymph, the scala vestibuli, this is the scala tympani, and this is the scala media area, and this is the Reisner's membrane, which divides this both, and due to and this is the stria vascularis present in the scala media. Okay, so here the production of the endolymph will take place, and due to some pathology, if the scala media gets totally occluded with the endolymph, then it will push this Reisner's membrane into the scala vestibuli, and that will cause the distension of the endolymphatic sac. Okay, and you can see there is no pressure change actually in an intact inner ear. There is no pressure changes across the two membranes. So these are the incidences. Generally, it's a slight female preponderance, and 10% will have a vertigo. So anything like hearing loss, vertigo, tinnitus, a Meniere's disease with some other underlying disease is known as Meniere's syndrome. If you have some others like syphilis, mumps, rabies, or something else, other disease, then it is called as Meniere's syndrome. The causes are idiopathic ischemia and vasospasm. Due to the decreased blood flow to the labyrinth, you will have this problem. Then emotional factors can contribute to it, and hydrops of the endolymph due to reduced absorption of the endolymph will cause Meniere's disease. Hormonal disturbances also sometimes, allergy, autoimmune disorders, viral infection, metabolic disorders, syphilis, and all. So all these are the some conditions where you can get, which can lead to Meniere's disease. Okay, sometimes anatomical causes such as small aqueduct, vestibular aqueduct. Vestibular aqueduct is small, then the passage is not the CSF which is produced will not be absorbed, so that might get collected in the scala media, and that will also cause the Meniere's trauma. So what is the pathophysiology? So how to understand this disease? Generally, what happens is endolymph will move from cochlea, where it is produced, to the endolymphatic sac, where it is absorbed. So the only thing you need to remember is endolymphatic sac will absorb the endolymph, and where it is produced, it's in the produced in the cochlea, where the stria vascularis and the scala media will produce the endolymph. So any disturbance in production or absorption results in accumulation of the endolymph in cochlea and membranous labyrinth, causing distension of the or hydrops, leading to distension and rupture of the Reisner's membrane. So due to the distension, due to the production problem or the absorption problem, this endolymph gets accumulated in the cochlea, and that will cause distension of the endolymphatic sac and also the rupture of the Reisner's membrane. So distortion of the cochlear duct produces hearing loss, while due to pressure changes, the labyrinth causes vertigo. So what is the reason for the vertigo? The reason for the vertigo is the pressure change, and hearing loss is due to the distortion of the cochlear duct. Well, you need to understand why do you have all these symptoms. So vertigo is due to labyrinth. There is some problem in the labyrinth due to the pressure changes. The labyrinth it gets irritated and will get vertigo, and that will cause in turn cause nystagmus. Then recording starts. Recording pattern. Recording video అని పెట్టుకున్నాను. Then any and hearing loss. As you know, the second symptom of this disease is hearing loss. So the hearing loss is due to the distortion of the cochlear duct. So as you know, we have cochlea and vestibule. Vestibule is for the symptoms of disequilibrium or vertigo. When you have a problem in your cochlea, you will have the problem for hearing. So due to this, we have these symptoms. Tinnitus is generally due to some abnormal sound produced that can be due to cochlear involvement only. That is also related with cochlea. And oral fullness is generally related to the middle ear or like inner ear. If some fluid is present, then you will have a sensation that it is full, something is full. If you have air, then it is normal. You won't have that fullness problem. But if you have something in it, then you'll have for example, you can imagine a balloon. If you just fill air in the balloon, then you will see that it is normal. But if you fill the balloon with water or something, then you can see that it's fullness, it's heavy, it gets heavy, it gets the fullness, you can feel it. So that is how you can explain this, the four symptoms. So this is the example showing that the diagram. So this is the normal cochlea, how you see, and in the cases of endolymphatic, in the cases of Meniere's disease, this the Reisner's membrane. So this is the Reisner's membrane. The stria vascular has produced the endolymph, but there is some problem where this is not leading into the endolymphatic sac. So the endolymph has to move from the scala media towards the endolymphatic sac, and if that is not going, so it's getting collected in the scala media and it is pushing the Reisner's membrane towards the scala vestibuli. So that is why there can be rupture of the Meniere's Reisner's membrane, and the patient will have all these four symptoms. See. Okay. So this is the image showing you the same thing. This is the cochlea and this is the endolymphatic sac. Okay. Okay. I'm sorry again. Last time also I had the similar problem. Um, well, this is so the block is at near the maybe at the cochlea level. So this is the cochlea. Okay. So there's no confusion. And this is the cochlea and this is the as you can as you know this is the direction of the flow you see. So this is normal. The direction of the flow is from cochlea towards the endolymphatic sac. So this is the cochlea and this is the endolymphatic duct and this is the endolymphatic sac. So there's no confusion here. I'm really sorry for that. um, you see the direction of the arrow. So this is the direction of the arrow. So the cochlea moves from the endolymph moves from the cochlea towards the endolymphatic sac. So what happens is when you have a blockage like this, when something gets obstructs the endolymphatic duct and prevents the flow of endolymph into the endolymphatic sac, then the cochlea will get distorted like this and distended like this, and that will cause the symptoms. So this is endolymphatic hydrops. Due to some problem in the endolymphatic duct, you are having hydrops. So this is the whole endolymphatic duct, right? And this is the cochlea. So it's getting distended. The cochlea from the cochlea towards the endolymphatic sac, the endolymph moves, and if there is any block, then in spite of moving towards the endolymphatic sac, it gets collected here in the cochlea, and that will cause the vertigo, hearing loss, tinnitus, and oral fluency. So what are the clinical features? As we know there are four features: episodic rotatory vertigo with sudden onset, and with mild or moderate, and it can be from mild to severe, and Tullio's phenomena. So what is Tullio's phenomena? It is when you're exposed to a loud sound, then you get this vertigo. So when you get a vertigo on exposure to a loud sound, then it is known as a Tullio phenomenon. Okay. So so this Tullio's phenomenon is seen in which of the following diseases? Meniere's disease, you see the Tullio phenomena. Perilymphatic fistula, you get to see this Tullio phenomena. Fenestration, when you have fenestration at the oval window or at the stapes and all, then you inner ear, somewhere in the cochlea also. If you have a fenestration, then you might here have this Tullio phenomena. Vestibular fibrosis, when the vestibular duct gets fibrosed, then you will have this Tullio phenomena. Fluctuating when people who are regularly wearing hearing aids or fluctuating load, because hearing aids, what happens is it amplifies the sound, right? Hearing, what does the hearing aid do? It amplifies the sound received. So when a loud sound is there, suddenly the amplification is much more, and that will irritate the inner ear fluids, and definitely the patient will have vertigo. So that is why the people wearing hearing aids will have sometimes hearing Tullio phenomena when they hear loud sound suddenly. And fluctuating low tone sensory hearing loss is also seen. Fluctuating hearing loss is a feature of all these conditions: Meniere's, Lemurey's, labyrinth and fistula, or metabolic disease like diabetes, hypothyroidism, hyperlipidemia, glomus jugulare, blue ear, and eustachian tube dysfunction. So all these conditions will have fluctuating hearing loss. Okay. And the second feature, the first one was episodic vertigo. So episodic spontaneous vertigo is one of the feature of the Meniere's disease. And second one is tinnitus, which is low pitch generally, and the patient may also have nausea, vomiting, and perspiration, gastric upset, and diarrhea due to vagal stimulation, oral fullness on the affected side. As we have already because it's filled with some fluid, right? So the patient will have oral fullness. Headache and anxiety may also be present. Intolerance to carbohydrates may be seen, because carbohydrates, when you take more, then the concentration of sodium will increase. So there's some alteration in the sodium and the potassium, so they will have some metabolic yeah, abnormalities, and that will irritate the cochlea, and you will have these conditions. So, and the most important point you need to remember is the duration of the attack. Between the duration of the attacks, because for suppose if he has an episode on August 8th and around September 24th, so in between these episodes, he won't have he will be quite normal. He won't have any of these symptoms. So duration of the attack varies from few hours to a few days, and in between the attack, that patient is normal. That is the point you need to remember. Okay. So what are the investigations and diagnosis? We do work here. We take the detailed history and we do the examination of the ear to rule out other external ear or the middle ear conditions. Tuning folk test will show you the sensory hearing loss. Putative audiometry will do impaired speech discrimination. When there is an impaired speech discrimination, then definitely that that implies that there is some problem in the inner ear. When you have an inner ear problem, when you have a problem with your cochlear nerve or vestibular nerve, cochlear nerve, generally sorry, vestibular means vestibular nerve will cause vertigo, right? So cochlear nerve, when you have a problem with your cochlear nerve, then there will be some impaired speech discrimination. And a caloric test will show definitely show some canal paresis, and recruitment will test positive, and short increments SI test will be done, which is generally better than 70% in most of the cases. Tone decay is done, tone decay of less than 20%, and glycerol test. We do a glycerol test, okay, that is we test to 1 to 2 ml per kg in lemon water is given, and is improved in hearing confirms that disease is acting by a dehydrating agent. When you give this glycerol in 1 to 2 that is up to 1 to 2 ml per kg in lemon water, so that will act as a dehydrating agent, so it will remove some of the water from the the endolymph will get secreted out, so that will decrease the distension at the resonance membrane, and definitely there is some improvement in the hearing. So that will confirm that this is due to a endolymphatic sac distension. Give me one second. We also do a we can also do a Beck's audiometry, which will show you type 2 tracings, and electrocochleography is also helpful in some cases. Okay. So this is the image showing of the normous membranous labyrinth. So this is the membranous labyrinth, which is quite normal. But if you see the condition of the Meniere's disease, you can see that this membranous labyrinth is totally distended. So these were the differential diagnosis. You have a you can easily diagnose Meniere's disease, acoustic neuroma, by BPPV, and vestibular neuritis. So these are the 4 conditions you can have as your TD when the patient, when a case scenario is given to you, like the patient has come to you with problems of vertigo, tinnitus, and all. Then you can have your TDs with Meniere's disease, acoustic neuroma, BPPV, and vestibular neuritis. But you need to remember one thing: if it's a fluctuating sensorineural hearing loss, then it is Meniere's. Progressive, then it's acoustic, and it is generally absent in both these conditions. Electro, and you can confirm it by doing the electrocochleography. So electrocochleography will come. Well, 8th nerve action potential will confirm your Meniere's disease. CSF study will confirm your acoustic neuroma. Actually, it's other way around. Okay, acoustic neuroma will be confirmed by electrocochleography 8th nerve action potential, because that is the problem with the nerve, and there is some mistake here. Cerebral CSF study will give you of Meniere's disease. So this table can help you to do a differential diagnosis. Okay. Staging of the Meniere's disease, what you do is stage 1, stage 2, stage 3. Means according to the Putative audiometry, you will do this, and there are some variants. If you have your first symptom as sensorineural hearing loss, then followed by tinnitus, and at last the vertigo, it's a lemorrhage. So lemorrhage is a reversal of the Meniere's triad. Whereas cochlear is primary symptoms are of only cochlea. That is only hearing loss will be the more common and tinnitus will be there. That is cochlear hydrops. When you have a hydrops and mostly only the vertigo complaint is there, then it's a vestibular hydrops. Atypical Meniere's diseases when complaints of some of only some complaints are there, because all the complaints are not there, then it's a atypical Meniere's disease. Secondary is when you have another means when you diagnose another conditions like syphilis is there, then it is a second means that due to syphilis the patient has this Meniere's disease. So syphilis was the cause which caused that Meniere's. So otosclerosis, Paget's, and after stapes operation, if you are getting this Meniere's, then it's a secondary Meniere's. And Tumarkin's crisis is when sudden falling attack of short duration occurs. Means when you fall off, the patient will fall off immediately in a very oftenly. So that is Tumarkin crisis. So this was the recap of the Meniere's disease. Then we'll go with the treatment parts on how you will treat this disease. So generally, for any disease, we treat we have two, medical and surgical, right? So first we'll go with the medical management. And before going to the medical management, as the patient comes to you with episodes of vertigo, so first you need to do a general counseling. You have to reassure that this might be due to these conditions. Okay, so they won't. This is not a major problem. I think you can get on with your lifestyle normally. You need to just stay calm and focus on your episodes and do some no smoking and alcohol. If he has a habit of smoking and alcohol, that might trigger so this disease. So you better tell him that you stop your addictions, and generally ask them to take a low salt and water diet, as most of the water is getting up. Its endolymph production will decrease if you take low salt and water diet. So that acts like a diuretic agents, like so if you give them a low salt and so if you make the solution hypotonic, then the water secretion will not be more in the in the endolymphatic sac, in the duct. So low salt and water diet will generally help if they have minor symptoms. And avoid overindulgence in the coffee and tea, and avoid stress by yoga and doing other activities. So you need to give them reassurance. You have to stop their addictions, take low salt and water diet, and avoid overindulgence in the coffee and tea, and avoid stress by doing yoga and other activities. So all these will be come under treatment of Meniere's disease as a general measure. Then conservative treatment in the acute attacks. When the patient has come to you with acute attacks and the patient is has come to your OPD, and he will tell he's telling that sir, I'm having this headache, vertigo, I have tinnitus, I have oral fullness. It's an acute attack. Then what you will do? You will ask the patient to admit immediately. If he agrees, then you have to ask him complete bed rest. He has to lie down and he has to take complete bed rest. Reassurance as usual, and you can give labyrinth sedatives like promethazine, chlorperazine, um, or some cynarazine. All these histamines. These are some antihistamines. H1. I think you have completed your pharmacology, right? If read long back, but we have antihistamines group 1, group 2, right? So antihistamines H1 will have this promethazine, prochlorperazine, and cynarazine. So these are all our vestibular sedatives. And you can also give a diazepam 10 mg IV. That sometimes that may also help. It's a antidepressant, right? A diazepam. So it will depress, means it will decrease the vertigo complaint. So diazepam is also given sometimes. Diuretics are given like furosemide 40 mg as required with potassium. And vasodilators like carbogen and histamine draw a drip, that is around 2.75 mg in 500 ml of glucose given slowly. So you what are you doing when the patient is having acute attack? Means already the hydrops is there, the endolymphatic sac is totally filled. So you have to ask the patient to take complete bed rest, reassure, and give some labyrinth sedative. Means you need to sedate the patient and make him sleep so that he doesn't feel that vertigo and all. So you can give like sedatives like cynarazine, promethazine, and chlorperazine. Diazepam can also be given, and diuretics are given to remove that extra fluid which is there in the cochlea. So by furosemide 40 mg is given, and sometimes vasodilators. As you know that ischemia is one of the cause of the Meniere's disease. So you dilate the inner ear vessels. So with that, what happens is the blood circulation will increase and the extra amount of the fluid will come out. So vasodilators, diuretics, labyrinth and sedatives are given in acute attacks. And treatment of chronic cases. The chronic cases means the patient has all these symptoms in 6 months, 8 months, and you cannot, and it's not acute, so he generally gets it, but not that often. So what you can do is you can ask the patient to take vestibular sedatives when he has these acute attacks, vasodilators as usual, diuretics. So these are the three which we give in acute also, and sometimes it is probanthine. All these are some drugs which you need to remember if you are asked, but generally you won't be asked in your finals at least all these things. And sometimes hormones may also means hormonal changes, disturbances were also one of the causes of Meniere's. So you need to check the thyroid profile, lipid profile, and treat them accordingly. And chemical labyrinthectomy is also indicated in some of the cases, like you can, if you have chronic cases and you have tried all these vestibular sedatives, vasodilators, diuretics, and still there is no improvement in this, in the condition of the patient, then you can opt for the chemical labyrinthectomy. Means what you're doing is you're injecting a chemical into the labyrinth. So the chemical which is here is injection gentamicin. So we give a gentamicin, which is a vestibular toxic. As you remember, we have vestibular toxic drugs and ototoxic drugs. So vestibular toxic drug is a gentamicin. That's why we don't give amikacin and gentamicin to the patients, because they are vestibular toxic and they might trigger the vertigo. So we don't prescribe generally in young patients this amikacin or gentamicin drops. I mean, amikacin injection, systemic injections we won't give, IV injections. So what we do is, how we do a chemical labyrinthectomy. So we give this injection gentamicin into the middle ear, either daily or weekly according to the symptoms, severity of the symptoms. Gentamicin profusion means it is generally the needle, means the needle is pointed towards the posterior inferior quadrant, that is at the round window area, because it has a thin membrane. It has a secondary tympanic membrane also. So through this, the round window, as oval window is totally covered with the footplate of the stapes, so you cannot infuse some fluid into it. Round window is open, right? So you can keep some drops of gentamicin into the middle ear at the footplate area, sorry, at the round window area, that is in the posterior inferior quadrant, and let the fluid get perspirated into the round window and reach the membrane, or reach the inner ear, that is the labyrinth. So gentamicin profusion of round window may give 80 to 90% control. In bilateral disease, injection streptomycin intramuscular is given. If it's a bilateral disease, then you cannot do. It's better you do a bilateral injection of the streptomycin. That is IM it is given. So these are the treatment for chronic cases. So as you give in the acute, you give sedatives, vasodilators, diuretics. Hormonal disturbances can also cause. So you need to check for the thyroid profile, renal profile, and chemical labyrinthectomy. If you have a bilateral Meniere's disease, then streptomycin, as already we have told, because streptomycin is primarily vestibular toxic and usually leaves hearing unchanged, indicated only for incapacitating bilateral Meniere's disease. So when you have a bilateral Meniere's disease, like you have audiometrically, you have documented that it is both sides sensory hearing loss, and the patient is complaining of both sides tinnitus. And when you check for the nystagmus, you have both sides nystagmus, left beating and right beating simultaneously. Then, or a horizontal nystagmus. If the patient has a horizontal nystagmus, then you can consider him as bilateral Meniere's disease. And then you cannot inject both sides gentamicin, so it's better to give them streptomycin IM, that is IM. How it is given? It is 1.5 to 3.5 gram per day until ice water response is absent, that is caloric response, and 20 gram, total dose is 20 gram. You can give up to a 20 gram. Okay. And there are some immunosuppressant therapy like chronic steroid. You can give them. You can put the patients on steroids for a chronic, like around 1 month, 2 months, and wait for the inflammation of the inner ear to get subside, and maybe that symptoms might get decrease. And NSAIDs, non-steroidal. So you're thinking about to as it is due to the inflammation of the inner ear. So you can also give some steroids and NSAIDs like methotrexate. Okay, immunosuppressant. Then this was the medical treatment management up till now. Now it is the surgical treatment. So when the patient has come to you with he has been coming to it around 2 months, 3 months, and 6 months, but there is no improvement. After you have done your reassurance, you have given them sedatives, diuretics, antidepressants, everything you have given. Then you have also given them chemical labyrinthectomy, you have tried, but still there is recurrence. Then what you need to do is you have to go for a surgical treatment. You need to explain him how to do means what are the options he has for surgical treatment. And surgical treatment has also two. If the you can, if the hearing loss is not much, means if the inner ear is good, is functioning, then you can go for conservative surgeries. But if there is no documented here, means if there is no hearing at all and it's a dead labyrinth, then you can go for destructive surgery. So what are the conservative surgeries? Endolymphatic sac decompression. So this is the most important surgical treatment we do. Generally, we prescribe the patient. So we do a endolymphatic sac decompression. So how do you do it? So by doing this, what is happening is we are decreasing the pressure in the endolymphatic sac, and the patient is relieved of the symptoms. So as you know that the endolymphatic sac is getting distended, so you have to remove that symptom. You have to remove that fluid from that. You have to decrease the pressure in the sac, which is causing the vertigo to the patient. So when you do this surgery, you are relieving the pressure in the sac. So briefly, the procedure is done you can generally done in a general anesthesia, but those who are well versed with this procedure and very experienced, they can also do under local, because as soon as you decrease the pressure in the endolymphatic sac, the patient will have improvement in the symptoms. So that's why this surgery is sometimes done in local. You can assess the patient on the table, well, whether he has relieved, whether hearing loss is improved or not, whether the tinnitus has decreased or not, oral fullness is decreased or not. You can assess the patient like you do in otosclerosis. Otosclerosis is also sometimes done in local, because as when you keep the piston, and you check for whether you have kept the piston right or wrong, and there is improvement in the hearing or not, you do it on the table. So like that, this surgery can also be done in local. So a simple mastectomy is done. You remove all the mastoid cells and you expose the inner ear. You try to expose the inner ear, and all the three semicircles are the horizontal, the lateral semicircular, and all these three semicircular canals are delineated. Endolymphatic sac lies close to the posterior semicircular canal, keeping in mind the Donaldson line. So this is a Donaldson line. There is a Donaldson line that this line is parallel to the endolymphatic duct actually. So when you delineate the three semicircular canals, you have a three semicircular canals, right? When you delineate this and draw a T-shaped line, you have to draw a T-shaped line marking the horizontal T, means that the horizontal line will be across the semicircular canals, and a perpendicular line you will draw towards the cochlea, towards the inner ear. Then that will show you the direction of your endolymphatic sac. So bone in this area is drilled with a diamond burr to expose the sac, which gets decompressed, thus relieving the symptoms. So what you do is you do a mastectomy, you delineate the semicircular canals, and you identify this Donaldson line, and you drill the bone over it, and try to expose the sac. Once the sac is exposed, you can make a small incision over it, and the excess fluid will be removed. The endolymphatic sac gets relieved, pressure relieved, and the symptoms will also get relieved. Endolymphatic shunt operation. There were you can also put a small tube, as we keep shunts in your heart to maintain the pressure changes in the major vessels. So you can also keep a small shunt there. So a tube is put between the subarachnoid space and the endolymphatic sac for drainage of excessive fluid. So you can keep a shunt. And another procedure is known as sacculotomy, that is fixed procedure. Fixed procedure is also done in most of the cases. Sacculotomy, the saccule is there, right? So saccule is punctured with a needle through stapes foot plate, and cord is so in the sacculotomy, what you are doing is a saccule, as you know, there's a saccule. So through the stapes foot plate, you try to puncture it, and the fluid will come out of the saccule. So that will relieve the symptoms. And Cody's procedure, that is places a stainless steel tag to periodically decompress the sac. So all these are generally very high-end procedures. It's a very small endolymphatic duct or endolymphatic sac, and to keep a shunt or to keep a stainless steel tag or to just puncture through the staples foot plate. These are all very minute procedures, but they are documented that these have relieved the symptoms in the menias. So generally, the most commonly done surgery is endolymphatic sac decompression. We do a mastectomy, we delineate the semicircular canals, we identify the endolymphatic sac by identifying the Donaldson line, and the bone is drilled out so that the sac gets exposed, and we decompress the sac. So this is the most commonly done surgical treatment. So coming to the conservative procedures, we have endolymphatic sac decompression, we have endolymphatic shunt operation, we have a sacculotomy, that is fixed procedure. And we also have vestibular neurectomy. We can also do a vestibular neurectomy because 95% will have complete resolution of the vertigo when you do a vestibular neurectomy. And the approaches are middle cranial fossa approach or suboccipital approach, retrosigmoid approach, or a retrolabyrinthine approach. So all these are the approaches where you can preserve the hearing loss. Okay, so the patient is means you can preserve the hearing for the patient. And sometimes we, as we have done streptomycin, means streptomycin and gentamicin injections and chemical applicability, we also do intratympanic injections of aminoglycoside. These are some minor procedures. So these are also surgical type. We can also go for a cryosurgery, ultrasound, or cochlear dialysis, cochlear implantation. If it's a bilateral to severe to profound hearing loss, then we can also go for a cochlear implantation. So that will improve the hearing of the patient. And sometimes the means like in the cases of cochlear eye drops, this will be helpful. The patient doesn't have any vestibular symptoms, right? So you can go for cochlear implantation. Then comes the destructive surgeries. So what are the destructive surgeries? You can go for a labyrinthectomy. Directly destroy the labyrinth, so that will relieve all the symptoms. When the serviceable hearing is absent and the pure tone average more than 60 decibel and speech discrimination score is less than 50%, then it's better you go for a labyrinthectomy direct. He's an old patient. There is no point in maintaining the hearing. So you remove the labyrinth and the patient will get symptoms relieved. So ablation can be done with hypertonic saline or transcanal or transmastoid procedures are done to completely destroy the labyrinth. Translabyrinthine cochlear vestibular neurectomy, destruction of the Scarpa's ganglion, or intermittent low pressure pulse therapy by using some devices like Meniere device to decrease the symptoms of vertigo. So these are all some of the destructive surgeries. So the destructive surgeries generally is labyrinthectomy or a translabyrinthine cochlear vestibular neurectomy or destruction of the Scarpa's ganglion. And you can and after these surgeries, then you have to explain them some exercises. There is exercises known as Hooksy Cochrane exercises. Generally, you can if you are really interested, you can search in your online, go to Google and search for Hooksy Cochrane exercises. These are some maneuvers of the head which will relieve the symptoms of the head vertigo. Okay, so these are generally adaptive exercises. This is of a brief flowchart. Okay, so conservative, surgical. I won't repeat all these things. You can easily go through this. You can take a photo of this. Treatment of the Meniere's disease, medical treatment, in between attacks, general treatment, and surgical, conservative, destructive. Okay. So this was the Meniere's disease. I hope you have understood a bit. No need to go into much details. Just understand what's the definition of the Meniere's, what are the symptoms or clinical features of the Meniere's, what are the variants of Meniere's disease, and how do you treat them. So these are the things which you need to remember. Just if you remember these small PPTs, small tables, then you can write your exams well. If someone has any doubt, you can unmute yourself and you can ask me some questions, or else if everyone has kept your attendance, then I'll end the class. Any doubts? If anyone has any doubts, then or else shall I close the class then. Okay then, I'll end this class. Thank you so much.